now we're going to talk about quinolones. We have already discussed the antifolates, sulfonamides, and trimethoprim being inhibitors of DNA synthesis, and now we're going to talk about inhibitors of DNA integrity. Um, we have the big title being quinolones, but really now what we use are the fluoroquinolone. So we started with nalidixic acid being a quinolone, but now what we have are the fluoroquinolones having this fluor here. Let me be more specific concerning the quinolones versus the fluoroquinolones. So here you go, nalidixic acid and siloxacin are the first generation quinolones, and they do not have the fluor here, so they are quinolones only. Whereas the second generation, the third generation, and the fourth generation, they are all fluoroquinolone. So all of them are quinolones, but from here on we have fluoroquinolones. Okay, and of course I won't be asking you specifically which one is second generation, which one is third generation, which one is fourth generation. I would be telling you that. However, if you see something that finishes with oxacin, 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 please know that this is a fluoroquinolone. Or a quinolone if you want, since we have siloxacin here. Okay. Now, how about the bacteria those drugs target? Well, the first generation are good for gram-negative bacteria, specifically in urinary tract infection, for example, E. coli. As we move down to the second generation, in addition to covering gram-negative bacteria in the UTI, we also cover some gram-negative in the tissues. How about Haemophilus influenza, for example? And we start covering some gram-positive bacteria. In the third generation, in addition to gram-negatives, both UTI and tissues, we have better coverage for gram-positive. And for the fourth generation, in addition to this and this and this, we have anaerobic coverage. Now I want you to realize that those lines here are not perfect. For example, you will see some drugs in here, for example, that do cover gram-positive and some anaerobes, but we are not going to be going to the specifics. We talk UTI, then more gram-negative, more gram-positive, more anaerobes. Okay. And by the way, when we talk about gram-negative bacteria, we think of Pseudomonas aeruginosa, and yes, we do have coverage of Pseudomonas aeruginosa, and this is kind of cool because we have fluoroquinolones that are given PO, and so what we have here is a PO drug for Pseudomonas aeruginosa, which is good. You will see other classes, some beta-lactams cover Pseudomonas aeruginosa, some of which are given only parenterally, etc. What I'm trying to say is that we have options and it's good to choose wisely. Now, why do I have pneumonia here? Well, pneumonia, for example, community-acquired pneumonia, the bacteria we think about are strep pneumonia and Haemophilus influenza, so both gram-positive and gram-negative, and also we can think of atypical bacteria such as Mycoplasma pneumonia. So we are considering several drugs, and we're not going to the guidelines of pneumonia here. However, if we want to consider fluoroquinolones, if we want to consider them, then we can give levofloxacin, gatifloxacin, or moxifloxacin. We call those the respiratory fluoroquinolones. We call them as such not because they are given by respiratory route, but because they are good to cover bacteria that we consider in community-acquired pneumonia, gram-positive, gram-negative, and atypical bacteria. Okay. This is a very busy slide. It might be scary for you. Let me explain it slowly. And I put this slide for people who have visual memory. I have a visual memory and I feel that this slide is useful to me. If you don't have a visual memory, you hate this slide, just ignore it. But it's gonna come back every now and then to haunt us if you want. So what is this? I downloaded this picture from one of the hospitals, and the susceptibility is going to change in different hospitals and different countries. So please don't look at the specifics, look at the generalities. In every hospital, as I said, based on the CDC guidelines, we have to look at our local data. And as a matter of fact, again, AUBMC releases its local data every year. And the way we use the local data in the hospital is like this, vertically. What do I mean? For example, let's say we discover that our patient has a Pseudomonas infection, and I look at the local data and I tell myself, so maybe I'm going to use those drugs. You will take those in the beta-lactams, VOP. Those are beta-lactams that are anti-pseudomonal. Or maybe I'm going to give a third generation cephalosporin, imipenem, whatever. It really depends on many factors and not just the bacterium. So this is how we read this in the hospital. We know the organism, and then we see what antimicrobials target this organism. But for the sake of our VOPs, how are we going to go over this? We're going to go over this horizontally. Every time we discuss an antimicrobial, we look at the spectrum of activity. For example, what have we done so far? We have so far done the antifolates, being the sulfonamides and the trimethoprim, and we talked that they were great in the beginning, and then now we really keep them for gram-negative UTI, specifically, for example, for E. coli. Again, you tell me, but doctor, you mentioned only this, you did not mention that. There are two things here. One, it depends on the local data, and two, I am focusing on the most important thing. And also now, if you go to the USMLE books, you may find some differences. It's okay, just focus on the basic principle. Like another basic principle for now, for the quinolones, the fourth generation, well, they're good for gram-positive, for gram-negative, including Pseudomonas. They're good for anaerobes, and they're good for atypical. This is the basic principle. Look at this broad spectrum of activity for the fluoroquinolone, the fourth generation fluoroquinolone. And you will see later some really good antimicrobials. Look at this coverage here that we'll discuss later. However, no coverage of atypical bacteria. So here we do have atypical bacteria coverage. Those are the basic principles I want you to focus on. So why do we love fluoroquinolones? Because of this broad spectrum of activity. We can give them for urinary tract infections. We can give them for sexually transmitted diseases if we are dealing with Neisseria or atypical bacteria, infectious diarrhea being Shigella, Salmonella, whatever, a diabetic foot infection being anaerobic, being staph, gram-positive, even in Mycobacterium tuberculosis. So when you'll see the tuberculosis with me, you're going to see first line drugs and second line drugs, and fluoroquinolones actually are among the second line drugs, and they can target tuberculosis, respiratory tract infection. We talked about fluoroquinolones. Now there's something really nice about them also, in addition to their broad spectrum of activity, is that they have a wonderful distribution in lungs, in the kidney, in the stool, in the bile, in the joint, in the soft tissue, macrophages and neutrophils. This is why they are good for tuberculosis, because they distribute inside the macrophages and neutrophils, and this is where the Mycobacterial tuberculosis is sitting. However, it's not good for CNS. So if you are dealing with a patient who has meningitis, you may have beautiful in vitro susceptibility, but in vivo it won't work. Now also we can use some quinolones such as ciprofloxacin as prophylaxis for meningitis. But you tell me, yeah, doctor, you just said that it's not good for meningitis. This is for prophylaxis. What does prophylaxis mean? It means that the patient does not have the infection yet. I want to prevent it from happening. This is different from empiric. Empiric, the patient has an infection, but I don't know what the bacterium is, and I'm treating empirically. Here, prophylaxis, the patient does not have an infection, and I don't want this patient to have it. So here, I'm not treating the CNS. In this case, I'm treating the upper respiratory tract. I want to prevent the bacterium from sitting in the upper respiratory tract, in the throat, and then going to the brain. Who are the target people in this? It's probably people who are working in the emergency room, and if they were exposed to a patient with meningitis, then we can give ciprofloxacin as a prophylaxis for meningitis, because those people were really exposed to this patient. What is the mechanism of action? Remember that we are talking here about DNA integrity, and what those drugs are doing, they are inhibiting bacterial topoisomerases 2. What are topoisomerases? They're known as the cell's magician. Well, I want you to imagine this as the DNA, and the DNA is usually like this, supercoiled. And then if the bacterium wants to grow, then you need DNA synthesis, right? Or RNA synthesis. You need the DNA to relax. And who does that? The topoisomerases. They relax the DNA when it's supercoiled, or when we have the two strands of DNA catenated together, they open them up. And I want you to imagine the DNA like the wire of the telephone. I don't know if you have a telephone at home with those wires that keep on being super coiled and catenated. Well, I have one in my office if you want to have a look. It's a pain. Well, the topoisomerase really relaxes that. So now to go back to our topic, the quinolones inhibit the topoisomerases, and hence what happens? You inhibit DNA synthesis. And I want to point out that we have here a concentration dependent killing and a post-antibiotic effect. I'm going to explain this when we talk about the beta-lactams. Keep it in mind, and you will understand this better in the next VOP. So again, we said that we are inhibiting topoisomerase 2 in the bacteria, and in eukaryotes we have the type 1 and type 2. But in this case, we're inhibiting topoisomerase 2, and we have several different ones if you want. And in the prokaryotic ones, we have two topoisomerases 2, being DNA gyrase and topoisomerase 4. So we do have some selective inhibition here. They do not inhibit the eukaryotic ones, but they inhibit the prokaryotic ones, specifically gyrase and topoisomerase 4. Obviously, if we inhibit topoisomerases in eukaryotes, here we are dealing with the anti-cancer drugs such as camptothecins and etoposide and amphotericin and others. Now we're focusing on topoisomerase 2 of the bacteria. We said we have DNA gyrase and topoisomerase 4. In gram-negative, DNA gyrase is preferentially targeted. In gram-positive, topoisomerase 4 is preferentially targeted. This one prevents supercoiling, while this one separates the catenated daughter DNA. And if I want to look only at DNA gyrase that prevents supercoiling, what it really does, the topoisomerase, it makes cuts, and as you see here, we have double cuts. It cuts both here, and then it turns the DNA and then attaches it together. We are only focusing on the DNA gyrase to see it again, how it works. Well, we have two subunits, the A subunit and the B subunit. The A is the one that cuts, and B is the one that gives energy. So as you see, it attaches to DNA, it cuts it, it turns it, and then it releases it, and then it's not supercoiled anymore. how do quinolones work? And those that specifically work on DNA gyrase, what you have here is that the fluoroquinolone will attach here and it will remain bound and it won't leave it alone, and hence this pathway here is interrupted. I want you to remember that quinolones are bactericidal. So far we talked about sulfonamides and trimethoprim, the antifolates, and we said that they are bacteriostatic. Quinolones are bactericidal at the therapeutic doses. At very low doses, the binding to the topoisomerase is reversible, but really at the therapeutic doses, the ones that we use, the enzyme dissociates from the DNA, but it keeps it broken, and the effect is bactericidal. Unfortunately, we do have resistance to quinolones. One thing that could happen is mutation of the DNA gyrase or topoisomerase 4, so this is changing of the target, or we may transport the drug out of the bacterium. Of course, you want it to be inside to work on the topoisomerase, so you would have active transport. There are many potential mechanisms of resistance, but what I put on the slides here are the ones that were proven, where there are studies, or they are the most common mechanisms of resistance. And in here, those are the two most common and proven mechanisms of resistance to quinolones. I said already that we like quinolones, and the main reason is, remember the spectrum of activity. For example, the fourth generation quinolones, they target gram-positive, gram-negative, anaerobes, and atypical. We said that we love them. Another reason we said we love them, we have options, PO options for Pseudomonas, for example, and or other bacteria, and we love them for some pharmacokinetic factors, the PO versus IV. For instance, levofloxacin, also known by Tavanik in the market, look at this concentration time curve, and you see it's almost exactly the same for PO and IV. So what? Here's the so what. So if you have a patient who's admitted for pneumonia and the patient is sick, so you start with IV levofloxacin, for example. 2 to 3 days later, the patient feels much better and you want to discharge home. Obviously, you will not discharge home on a PO drug, on an IV drug. You want to discharge on a PO drug. And because the pharmacokinetics here are exactly the same, it's very easy and simple and straightforward to simply give the drug as PO with the same dose, and no worries, I am sure I'm going to have the same effect like the effect I was having in the hospital. So those are some nice quinolone pharmacokinetics, and this example is specific for levofloxacin. Another thing is that some of them have a really long half-life. For example, ciprofloxacin has a 4-hour half-life. Trovafloxacin has a 10-hour half-life. So many times we give the fluoroquinolones once a day only, which is kind of cool. Imagine yourself going home with an antimicrobial that you have to take 3 times a day, then compliance becomes an issue, and you really want to be compliant with the antimicrobial. If you're not, if you stop the antimicrobial or you don't take it well, what's going to happen? Well, you're going to have resistance. So yeah, it's good to have a drug that you expect patients to be compliant with. Finally, adverse effects. Unfortunately, of course, there are some adverse effects. There are some cardiovascular ones, and sometimes we fear prolonged QT interval. CNS, the patient may have headache, dizziness, sleep disturbance, etc. So remember that those may happen. Some skin adverse effect, rash, pruritus, photosensitivity, etc. We may have effects on the liver. We may have effect on the kidney and other allergy. But what I really want you to remember very well are the musculoskeletal adverse effects. We may have arthropathy, tendinitis, and even tendon rupture, and that was seen in animals. And because of this arthropathy and tendinitis, fluoroquinolones are contraindicated in children. You cannot give them to patients who are less than 18 years of age because of that. So maybe it may be the best drug for this bacterium, but you simply cannot give it if the person is a child. I put here two slides, not for your memory, differentiating each fluoroquinolones, because when you move further with your clinical years, you're going to have to differentiate a little bit, do I use this one, do I use this one, and why, etc. And this slide is also not for your memory, but there are specific adverse effects for some specific drugs.